Hi everyone. Good evening. I'm Dr. Mohid Khan, consultant gastroenterologist and lead the NET service in South Wales. Um, Hopefully you can all see my screen and can hear me okay. And if anyone can't, just let me know online. If there are any questions, just leave them to the end, or you can type them in the Q&A and I can answer them at the end. So this is a talk on NETs, gastroenteropancreatic NETs for primary care. And the first thing is terminology, so NETs or NENs. So this is uncommon in primary care, but it's more common than one would think. And it's the old word is carcinoid, which you may have heard about in the old textbooks, but over the last couple of decades, we're using the word neuroendocrine neoplasm, or NEN, or neuroendocrine tumor, NET. And these are three individuals, all had pancreatic NET. So Steve Jobs of Apple had an insulinoma from a pancreatic NET. Aretha Franklin and Irfan Khan also had a pancreatic NET. And where do they come from? So cancers, obviously, cells and carcinomas are cancers of epithelial cells. So these are cancers of neuroendocrine cells. So unusual, but neuroendocrine cells are normally sort of comprised in different tissues around the body. Those that form glands, so pituitary, parathyroid, paraganglia, and those that are just distributed diffusely through the tissues. So spread in the lining of the gut, pancreas, skin, thyroid, lung. There are small groups of neuroendocrine cells or in isolation. And these are the ones that transform and form neuroendocrine tumors. The old term was carcinoid, which we still use for carcinoid syndrome, but carcinoid is the old term, which sometimes may be used in the States as well for when the rest of the world in Europe state neuroendocrine tumor. They can arise in different parts of the body. So it's not just like bowel cancer, colorectal adenocarcinoma. There are NETs which arise from the bowel. So NETs can start or have their primary in the stomach, gastric NET, pancreas, pancreatic NET, small intestinal NET or a midgut NET, or jejunal NET, depending on if it's in the jejunum. But we see them in the lung, the colon, the appendix, the rectum. And they can behave slightly differently depending on where they start. Are they rare? No, they're less rare than one would expect. The blue line, incidence of all cancers in the States over the last few decades. The orange line, steeply rising as that, the incidence of NETs. So the survival was varied. And so that's why it's quite strange tumor. So busy slide, but all you've got to realize here is the y-axis, which is the survival rate in months. And it goes up to 400 on the top graph, for example, 400 months. And you can see that very localized appendiceal NETs have a median overall survival, which is extremely long, over decades. But then some of these distant metastatic disease, the third of each column in each site. So the colon NET, the distant disease, it's very, very short, so aggressive. And you've got varied survival. But even in the metastatic setting, so that's the third of the column, in the small bowel, if that metastasizes, patients can survive a median overall survival of 7 years. And because of that, there are patients that walk around with NETs and live with NETs for many years, even decades. So it becomes quite prevalent, and it is the second most prevalent GI cancer in the States. There are ways to classify these NETs, but one important way is whether they're producing hormones or not. As I said, Steve Jobs' NET produced insulin. He had an insulinoma. Gastropancreatic nets, you can split into whether from the pancreas or from other parts of the gut. So from the pancreas, if it's functioning, producing hormones, you can have an insulinoma. It's rare, 1 in a million. But then you have these other rare syndromes. But most commonly, the pancreatic net does not produce any hormones. And it's usually then presents with symptoms related to tumor mass. The non-pancreatic is mainly the small bowel nets. If they're functioning, they can produce serotonin carcinoid syndrome, but I'll come on to that. So the small bowel or midgut nets, which is the classical carcinoid in the old textbooks, about a quarter of all the GI nets, 2/3 are metastatic at the time of diagnosis, so quite late, and a small proportion have carcinoid syndrome with flushing, diarrhea. And this is someone with facial flushing from carcinoid syndrome, and it's a dry flush triggered by alcohol, stress, and importantly, it's not usually a wet flush associated with the menopause, so not the hot flushes usually. It's a dry flush, which comes on and lasts minutes, maybe longer, even seconds. It's due to serotonin and other compounds, and that can cause the secretory diarrhea. So although there are a number of symptoms listed here, the diarrhea and flushing are the most common in carcinoid syndrome. But remember, the majority of midgut nets don't produce this. And importantly, it can cause thickening of the pulmonary valves. So serotonin produced by some of these tumors is metabolized in the kidney into the urine, and the metabolite is 5-HIA, and it's that which we can measure in the urine. And some biochemistry here comes up in the question. So tryptophan is amino acid which produces nicotinic acid, vitamin B. And there's an abnormal metabolism of tryptophan in NETs, or carcinoid syndrome, where there is much more serotonin produced and therefore 5-HIA, which means you get a diversion of tryptophan away from nicotinic acid. And so very occasionally one may present with vitamin B deficiency, nicotinic acid deficiency, or pellagra. And there are blood tests which you use in hospital, and one of them is chromogranin A, and I don't think it's a very good test in primary care. Sensitivity varies, and it's falsely positive in a number of areas, diseases, if you're using a PPI. And it's not raised in quite small volume nets. And it also can be difficult to send to the laboratory quickly on mice, etc. So it's something that the hospital would do. The carcinoid syndrome can result in carcinoid heart disease, which is fibrosis of the valves of the heart, usually the right side. So the liver metastases will produce the serotonin and hit the right side, and you get tricuspid and pulmonary regurg. It's not metastases into the heart muscle, which is separate, but we do see that. And if you have valvular fibrosis, you can present with right-sided heart failure. So edema, raised JVP, shortness of breath on exertion, congested liver. And this carries quite a high mortality rate with a 30–50% reduction in the expected survival. However, things have improved because we're better at treating NETs. So looking at diagnostic end, some of these NETs can be difficult to diagnose. And looking at the survey, patient survey, most common mislabel is IBS or Crohn's. And that can be made in primary care or secondary care. And that's a common theme that we see. The symptoms, mainly the GI NETs, if you forget the gastric nets, which are usually incidental, and the rectal nets, which are also incidental, but the other types of nets, abdominal pain is very common, diarrhea, a bit of weight loss, the facial flushing for those with carcinoid syndrome. 2/3 have chronic symptoms, so those are the types of patients you may see in primary care with chronic GI symptoms. They may be presented a number of times to primary, secondary care, and those are the ones to be aware of this diagnosis. But almost a quarter in this group in Wales presented acute emergency, small bowel obstruction. So those are the ones that we're trying to prevent and make an earlier diagnosis. But again, these can be asymptomatic and incidental and picked up on imaging for other things in approximately 10%. We looked at the cohorts in Wales and who diagnosed them eventually, and generally the GI surgical teams and the gastro teams, the vast majority, 80 to 90%. So those are the specialities you may refer to, but you may not suspect in that. You may have a patient in primary care with gastrointestinal symptoms, which you may think is IBS or Crohn's or IBD, and you're referring in. Now, you'd hope that secondary care would make the diagnosis if it was a NET and they've excluded the other things, but beware of patients discharged back from secondary care because they may not be aware of NETs. And through education in secondary care, we can improve diagnoses at times, as we have proven in South Wales. So this can be diagnosed or suspected in primary care, and it's usually those patients who may have had IBS at an older age group. Beware of making the IBS diagnosis in an older age group. And this is the diagnostic algorithm, but you don't need to focus on it really. The key thing is in the center. Imaging will diagnose a NET in the small bowel, usually with a lymph node and in the liver. Occasionally, liver metastases may not show up on CT, but generally imaging will happen. If you have access to CT, especially if someone's had chronic abdominal pain and you haven't found any other cause, and they are of an older age group, CT imaging is the first line investigation after your routine blood tests, excluding celiac disease, etc. And importantly, it's up to secondary care to obtain a tissue diagnosis. So like any cancer, biopsies are taken and to look under the microscope. So the classical story of a mid-gut or small bowel NET is this. 57-year-old female, she has 6 years of intermittent loose stool, poorly localized mild abdominal pain exacerbated by stress. She could consider, it could be IBS, but remember her age. She had normal investigations after being referred, ultrasound and a colonoscopy. So everyone seemed to be reassured. But actually, she was referred twice because she had repeated presentations in primary care and then again referred to secondary care. And that's another alarm bell to look for other causes, despite a normal colonoscopy. She was given the usual IBS treatment after excluding other diagnoses. And although there was a mild degree of weight loss, this had stabilized. So you may not have those red flag features. She was referred to secondary care, who arranged another second colonoscopy, but then she was referred to surgical colleagues who then undertook a CT colonogram, and this was found. So on the top left, on the arrows here, you've got calcification, white in the middle, surrounded by fibrotic mass. So that's a mesenteric mass. So lymph node metastases surrounded by fibrosis. And it's on the bottom right here, it's drawn in on a cross-sectional imaging here. It's drawn in stellate appearances, so it's tethering and causing a degree of small bowel holdup. And eventually, the patient would present with obstruction. And there's a liver met here in the middle. Now, the markers were normal. The 5HI was normal, chromoglobin only slightly raised. So although there are fancy blood tests, etc., that you may think of with NETs, imaging is the key to diagnosis. And then, as I said, the golden sort of diagnosis is a biopsy. The patient had a liver biopsy, and this shows a NET. And obviously, we may not have the skills of our expert pathologists, but they will report neuroendocrine cells in various shapes. And the black cells are those that take up a particular stain, Ki67, which is important just to be aware of. So you may get a pathology report that you're staring at on the computer or on a piece of paper, or someone's written for you from the hospital. And first of all, is it a neuroendocrine neoplasm or neuroendocrine tumor? They may use the word carcinoid. And the Ki67 staining is important because the higher the percentage, the more aggressive the cancer is. So the cells that take up the stain are an active mitosis. The more mitoses are, the more active the cells are in dividing, and therefore more aggressive. So this is 6%. And we can use that to determine grade. And this is the table according to classification in Europe or WHO, of grade. The higher the grade, the higher the Q67, the higher the grade. And we also use differentiation. How well do the cells look like the original neuroendocrine cells? And if they don't, and they're completely out of shape and they've lost all control, cellular control, they're poorly differentiated. We call that neuroendocrine carcinoma, and they're very aggressive, or more so than bowel cancer, the standard bowel cancer. So grade is prognostic. This is a Kaplan-Meier survival curve. So the shallow line at top is grade 1. Patients remain, a good proportion of patients remain alive. Here we're talking about 48, 60 months. And the higher grade, people are dying. So higher the grade, the worse prognosis. So this is important to know, to be able to communicate to the patient. Because if you've got a low grade NET, there is a lot of time, patients survive a long time, and it's quite indolent. This is how I explain NETs to people, and you may be able to explain to your patients if you come across any who could diagnose in secondary care. To have a line, a cancer spectrum, malignancy spectrum. NETs are always malignant. There's some debate about that, but they're cancers. This line, on the left-hand side, benign things like polyps. On the right-hand side, aggressive cancers like the standard pancreatic adenocarcinoma. And then traveling from the right-hand side down to the left, you'll have bowel cancer, breast cancer, aggressive cancers, but can be treated with advanced therapies, and people survive for a number of years. Lymphomas and some other blood tumors, and then prostate cancer is quite slow growing, as we know, people can live with prostate cancer and then die from something else. So towards the left-hand side. So NETs can occur in anywhere on this line, but most NETs, low grade, middle grade, are down this end, slow growing, similar to prostate. The neuroendocrine carcinomas, the more aggressive, poorly differentiated, are up this end and very aggressive. So that's something you can use to help to communicate to patients. The only thing to take from this slide is somatostatin receptors, which are present on most low-grade, mid-grade NET cells. And we can use those receptors to diagnose and for therapy. And if you label octride molecule, which binds to those somatostatin receptors, and you label it with indium-111, that's a radioactive particle, then scintigraphy can show up NET cells where they are because the somatostatin receptors are labeled. We have in UK, we have access to gallium-dotted PET scans, which are much more sensitive. And at the bottom, you can see some very nice pictures where the liver metastases are light up due to the somatostatin receptors being positive. So that's gallium, radioactive gallium attached to octreotide, which is injected in the patient, and then they have a PET scan. And it's different from the normal PET scan that you may have heard of for aggressive cancers and bowel cancers, lymphomas, which tend to show the very active A-grade cancers. But it is this type of PET, the normal PET, is useful for the very high-grade NETs. So the treatment, I'm not going to go into too much detail because it is quite complicated, but and patients may have different treatments, but surgery, if it's localized and you can cure, somatostatin analogs, which are the mainstay, which I will talk about a little bit, liver-directed therapies like embolization and radiofrequency ablation, you might find those overlap with other liver tumors. Oncologists can use molecular targeted therapies, some newer drugs, everolimus, sunitinib, tyrosine kinase inhibitors. Standard chemotherapy, which is not terribly useful in most NETs, but can be used in the higher grade NETs. And then other systemic therapies, which I won't go into. So the important thing is that if patients survive a number of years, they can have different lines of therapy. So they may have 1, 2, 3, 4 lines of therapy. So that's important to know and be able to communicate to the patient that it's not a one-size-fits-all. And they may have surgery at one point. They might have surgery years down the line after having other treatments. So this can be quite difficult for the patient. And so therefore they do need support. And therefore it is worth knowing a little bit about the different lines of therapy that they may have by reading letters. And importantly, the patient should be managed in the Centre of Excellence, Neuroendocrine Tumour Centre of Excellence. We have European Centre of Excellences across the UK, including in South Wales and across Europe and the States, and Australia, I think, as well. So there are a number of specialities that contribute to the care of these patients, and they're all important, and some are more important in some centres than others, and some more involved in certain types of nets than others. And it does require a good multidisciplinary team meeting and team. And remember the somatostatin receptors that I talked about was present on quite a lot of pancreas and midgut nets. So we used it for diagnostic imaging with the gallium PET and the octide scan. We're going to use it for therapy. If you look at this diagram, the circle is something called somatostatin analog, which is an injection once a month, a long-acting injection once a month, which injected into the buttock or the thigh, and it targets those somatostatin receptors, and it can reduce the hormones produced by the tumour. So it can, with those carcinoid syndrome features, flushing, diarrhea, it can inhibit the secretion. But also, over the last couple of decades, it was known to slow the growth of the actual net. And so there are good randomized controlled trials, and this is standard therapy now for most nets that can't be completely cured with surgery. So we have octreotide LAR, and we have lanreotide autogel as the two main somatostatin analogs that we have access to. It's every 4 weeks. We have home care available, but may need to administer it in the practice, but it's usually with some sort of shared care if it exists. But quite commonly, most centres of excellence do control and are able to prescribe through home care services. If you label octreotide molecule with something very radioactive like lutetium, a beta emitter, and then you inject it intravenously, you can actually home in on those somatostatin receptors and take those beta emitting particles. So it's like a homing missile or magic bullet therapy. And this is what PRRT is, or peptide receptor radionuclide therapy, available in some centres in the UK and throughout the world. And it's shown to have good evidence of slowing progression. And you can see here, somatostatin receptors are targeted with that somatostatin analog, but labeled with the radioactive isotope. Another drug that can be used, the centre may start the patient on, is if those carcinoid syndrome features are still present despite those octreotide or lanreotide injections, there's a way to block the production of serotonin peripherally through something called telotrestat tablet, just been out a few years and licensed, and it inhibits this enzyme, tryptophan hydroxylase. And so that blocks the peripheral production of serotonin, and therefore less diarrhea and flushing. Remember, the patient may have surgery at various time points and may have surgery even if it can't be cured, which is unlike other cancers. So in a metastatic setting with a small bowel net and liver metastases, some surgeons may opt to remove the primary tumour, but leave the liver metastases in, which seems counterintuitive, but actually is to stop the progression in the small bowel of fibrosis and obstruction. So you're trying to prevent something further down the line or improve symptoms. And some patients may have liver debulking as well. So it's important to have a multidisciplinary team. And this is the fibrosis, which I talked about. And this you don't want to get into if you're a patient, because this can be almost incurable. The only cure is if someone had removed as much as possible up front. When you get to the scarring stage, unless you bring out a stoma or some bypass procedure of the bowel, it's really managing the symptoms, dietary modification, parenteral nutrition, etc. There are standards and guidelines which secondary care can refer to. So European Net Society guidelines. We have the UK and Ireland Net Society, which are more sort of shorter in bite size. But the ENETS guidelines and also the charity in the UK, the Neuroendocrine Cancer UK, NC UK, has a vast array of patient information, which is one of the best websites for patient information in the world. And that's the thing you should probably direct your patients to if they've not already done so through their centre. And importantly, even if the NET is treated, as in tumours treated, the syndrome is treated, they may have other symptoms semi-related to that NET or the surgery. So this is prevalence of gastrointestinal symptoms on questionnaire in Wales, and you can see steatorrhea, wind, abdominal pain. So it's a chronic disease and may require things like pancreatic insufficiency treated, because SMAP analogs can cause pancreatic insufficiency. So they might require cranial to help steatorrhea. Or if someone's chopped part of their small bowel out, they may develop bile acid diarrhea. So they might need cholestyramine, Questran, cholesevelam. And may develop bacterial overgrowth because of stasis in the bowel, which might require antibiotics. So there are chronic GI symptoms which may require treatment in some patients again and again. I've no references, but this is a book that's been published today on GI symptoms, but it's aimed at children. But hopefully that's something which your kids will enjoy. I'd like to thank you very much, and I will open the floor for questions if there are any. So I'll leave a couple of minutes or so. I did receive some questions during the sign up, and so one of the questions was around the terminology. And someone thought this was related to the brain because of the word neuro. That's a misnomer. I guess it's quite confusing, and the terminology hasn't been really helpful, the different changes in language with the societies. But neuroendocrine, it comes from the fact that some of these cells will produce hormones for natural physiological reasons if it's just a neuroendocrine cell, or if a neuroendocrine tumors, some of them produce hormones. And under the microscope, the hormones sit in little vesicles similar to the neurotransmitter in neurons. So that's where the neurosecretory element comes from. And that's why it's called neuroendocrine, because there's a neuroendocrine control. Certainly with the glands, pituitary, certainly it's pure neuroendocrinology. So that's where the term comes from. And that's something we're probably not going to go back to the old term carcinoid. And the other question we received was something around the diagnosis of in primary care and when one should suspect someone's got vague GI symptoms, because IBS is very common, and there are other more common diseases in primary and secondary care related to the GI tract. So and that was a really important question, because you may have your standard IBS type patient who has who's young, who's had symptoms which are quite classical according to Rome criteria, and you may do a celiac screen as just a minimal investigation, which is negative. That's fine in your 20-year-old, early 30s, but as someone gets older, if someone has new onset or symptoms over a few years or so, and they're vague GI symptoms, bloating, abdominal pain, and they've had negative tests, one must consider this diagnosis, and it may not be up to you in primary care, but just to refer into secondary care and beware that patient with normal colonoscopy, because quite often patients are triaged in secondary care outpatients straight to endoscopy just because they have some GI symptoms, have a colonoscopy and are discharged. But no one's found an answer to their symptoms. And it's important to maybe push back and ask the question, are there any other diagnoses to consider, such as neuroendocrine tumor or even bile acid diarrhea, etc. And that just makes secondary care, whether it's GI surgery, gastroenterology, think about it. Just looking and seeing that I don't think we have any other questions, but my email and Twitter address is on the screen. or was earlier on. I'll just put it up there again in case you want to contact me. And I will now draw this evening to a close. Thank you very much.